go.
Hello everybody and welcome to the latest in our series of anaphylaxis campaign webinars. Those of you who viewed our webinars before will know that we've been running these over the past year. It was a new way of working for us, but it helps us to get our information and support out to as many people as possible, particularly during this interesting time. Today's webinar is about allergy in the time of COVID-19, a year of working differently. And I think that's something we can all empathise with. And our speaker today is Deborah Marriage. Now, Deb has been a fantastic supporter and friend of the anaphylaxis campaign over a number of years. She's quite a prominent figure in the allergy world, I think it's fair to say, and will be known to many of you. Just to tell you a little bit more about Deb, that she currently works as a consultant in allergy and asthma at Bristol Royal Hospital for Children, and she's been working there since 2002. Prior to that, she worked at St Mary's Hospital in London, and she's completed the MSc in allergy run by Southampton, which is a course that's still running, of course. And she has a professional doctorate in health from the University of Bath. Deb may be known to many of you because she has been a very active chair of the BSACI Nurses in Allergy group, and she's a very strong advocate for nurse-led services and promoting the extended role of nurses. She enjoys research, and her particular interests are in asthma and in egg and nut allergies. So without further ado, I'd like to hand you over to Deb.
Thank you, Lynn. That's a very kind introduction. I feel quite humble. Before we start, I just want to say that we've had a few IT problems. So actually, I'm going to get Lynn and team to share the screen for me. And it would be really nice if people want to talk or ask questions as we go through, if that's possible. I'm not sure it is, or to submit the questions and we'll go through them at the end. I'm hoping that this will be quite a nice light-hearted session. It feels a bit like show and tell at primary school, but what I would really like is for people to all learn from each other. So can I have the next slide, please? Thank you. So as some of you might know, Bristol is quite famous for having brought up Banksy. I don't think this is a Banksy, but this is a mural of the girl with a pearl earring with a little mask graffitied on the top, which I quite like. And it's kind of a nice introduction for a talk on COVID, I think. Next slide, please. So before the pandemic hit us, these are the centres that we used to work from. So on the left, you've got the main Bristol Royal Hospital for Children, which is where a lot of our outpatients take place. And on the top right, we've got Southmead Hospital. We also have a large number of allergy clinics which are set from here. And our clinic is below the police station, which sometimes is handy. And then on the bottom right, this is South Bristol Community Hospital, which is a new build hospital built about 5 years ago that we rent. The trust rents the whole hospital, and we also have allergy clinics running from here, which is a great place to work from. Can I have the next slide, please? All of our food challenges and things take place within the Children's Hospital. It's just the outpatients that go to the other centres. So this is quite a nice picture of our main square, Queen's Square in Bristol, at the beginning of spring last year. So these are socially distanced circles for people to meet in. And it's the social distancing really which gave us all the problems. So because of social distancing, hospitals were unable to see as many patients as they had done previously. So that's both inpatients and outpatients. And of course, I think some of the concern for people working in allergy is that because it's, well, most of it's based in outpatients, isn't it? It's not an acute condition a lot of the time. Obviously, it can be. So there's a danger really with something like allergies is that you would get pushed to the ends and priority would be given to other services for the rooms. Next slide, please. So here begins the problem solving process. So I quite like this slide. So first of all, the problem really is social distancing, I think, and reduced access to beds and rooms. So you have to kind of think what you can do about that to make a difference. And we had a lot of brainstorming about different ideas, different ways of working. And we finally came up with a few plans, which I'm going to go through with you. And then we had a bit of success with our plans. So some of them came to fruition and some of them didn't. Next slide, please. So obviously I'm going to go through the ones that were successful. So what we've got here is a picture of the Nightingale Hospital in Bristol, which I'm going to talk about, and also the Spire, which is a private hospital, which I'm also just going to mention. And then if you press next slide, there should be another picture that obviously hasn't come up with the others. So this is our mobile allergy clinic, which was the first idea that we had. Next slide, please, Joe. Okay, so wandering through Bristol one night, I came across this vehicle here. So this is the mobile allergy clinic before it became the mobile allergy clinic. So at this point in time, it's what we might call a drunk tank in the city centre. So if someone's drunk in the town, they get hauled into this vehicle where they sleep it off, and then they can go home safely, really, at the end of the day. It's also used, it has been used for COVID testing in the early days and things like that. They call it a mobile treatment vehicle and they rent it out to other centres. So this gave them the idea of using it really for our clinic. One of our consultants has often mentioned that it'd be really great to have an allergy bus. So that's what gave me the idea, really. Next slide, please. So this is it when we had it up and running. So this is in one of our shopping centres. So the Mall at Cribbs Causeway, which is a big out of town shopping centre. We were able to get a parking slot where we could rock up once a week with our vehicle. The nice thing about this is that it drives up like a lorry, and then you press a button and it opens out from the front and from the back. So it opens out sideways. And it's actually a really big space inside. Next slide, please. So this is the tricky bit. So when I first suggested having an allergy bus and using that vehicle, I think everyone thought I was completely mad. So persuasion is the key, definitely. And I've learned that there's a skill to this, which I don't think I had before, but I think I am developing. So what you need to do is to get someone to agree to something that there's no way they would otherwise agree to. No, they wouldn't think of it, and they probably wouldn't say yes to. So how do we do that? That's the really important thing for us to think about going on. Next slide, please. So I took the inspiration from my sister-in-law, Helen, and she runs a lot of visual arts displays in London. And I'm trying to think how long ago this was, maybe 15 years ago. She took over the streets of London and there were some large robots moving around the centre. So this is a huge elephant that walked down the Mall. It went through Piccadilly Circus and all those places. So she had to get half of London to agree to this, get roads closed off, all this kind of stuff, take out insurances for royal deaths, all this kind of stuff. And she said, I found this quote in the Financial Times, which I really like, but she said, don't ask permission to do things. You make people think it's already up and running, which some of you might not agree with. It's a bit of a trick, really. But yeah, so if they don't think you're asking their permission, they don't feel responsible for what you're doing. So as long as you're willing to be responsible and take all the responsibility, it's an easy way of getting permission. And this article in the Financial Times is called How to Make People Say Yes, so it's worth having a look at. So next slide, please. And I just want to add this, and I know this is not a very easy thing if you work within the NHS to deal with. So for example, today, I can't share my screen myself because my trust have blocked Zoom. So it's nice and easy to say we can invent them, and I guess we can, but it isn't always very easy. Next slide, please. Okay, so these are all the things that I had to go through in order to get the clinic up and running. Actually, getting management to agree was really easy. They said yes straight away, which actually took me by surprise. I think there was a little pot of money labelled COVID money, so they assumed they could get the money for it, for the paying for the vehicle from that. And it was £300 a day. So I guess in terms of inpatient and outpatient revenue, it's not a huge expense. So the most important thing that they seemed to be interested in was getting the appointment letters sorted on, I think they use something called Synergy, but whatever central appointment letter system they use, getting those changed is apparently tricky and seems to take a long time. So I can't point, but the bottom right hand letter is the one that they were interested in. So we took a bit of time sorting that out with the admin people. Thank you. And then top left is the COVID screening questionnaire. So when people were phoned for their appointments, obviously everyone gets asked all these routine screening questions. The other thing that we have, there's a document with a picture of a lorry on it. So that's the proposal for the service, which is like a two-sided document that I had to write for our business manager. Then there's a risk assessment form as well. So that looks at things like, what are you going to do if someone has anaphylaxis in the car park? Really unlikely for skin testing, but we need to have thought about it. What are we going to do if someone falls down the steps? I think that was probably the largest risk. What are we going to do if someone's sick? All these kind of things. What happens if a stranger runs up the steps and tries to beat us all up? All that kind of stuff. So we had to think about that. And then we had to get a map sorted, patient directions, bus routes needed sorting so that patients coming by bus would know how they were supposed to get there. And we were really lucky in that our hospital charity, the Grand Appeal, did all of that for us. And they also negotiated with the centres where we parked our vehicles. So Ashton Gate Football Stadium and the Mall, they have links with them. So they did all of that for us. And then the large document that scans right across the middle is the kind of protocol for the running order of the day. So things we need, how many patient slots we've got, that sort of thing. And then finally, we did a patient information sheet, which is on the bottom right. Next slide, please. Okay, so these are just the logos for our hospital charities. They were really helpful, and they sorted out news coverage as well. So unfortunately, we had to be interviewed by the BBC, just so that patients coming locally, knew about the initiative, mainly to make them check their clinic letters and go to the right place as much as anything, but also to be a little bit reassuring. Next slide, please. And this is inside the vehicle, so it's larger than you think actually when you're on the inside. So this is myself and my colleague Esme, who's one of our CNSs. So we have all the emergency equipment we need already. So we've got oxygen, suction, needles, syringes, medications in there already. And we did take our own. It's easy to wipe down between patients, and patients can wait in their cars, so they didn't have to freeze to death outside, most of them. And I think if you think camping, you're about right. So that bottom left image of, the signposts, all the kit, the skin tests in the cool box, the nebulizer machine, just in case, all those kind of things. So it was a bit like that. So we did have to bring things from the hospital to the vehicle and take them back again every day, which is a little bit of an effort. But given that it was our only way of seeing patients during the summer on a face-to-face basis and performing the skin testing, it was well worth it. And a little camping table on the bottom right, which we bought from Aldi to do our testing from. Next slide, please. And it ran every week for 10 weeks, alternating between these two sites. And we had 15 patients a day. So they were given half an hour and we did a quick clean down between patients. On the days when Bristol City were playing football, we had to leave earlier because in the terms of the footballers' I think, return to work. They weren't allowed to go near any members of the public, so they wanted us well out of the way, and that wasn't a problem. So we had 119 children attend, and we had 110 complete a patient feedback survey for us. So I just set that up really quickly on Google Forms, just because I wanted some kind of feedback, partly for this service, but also because at the back of my mind, I was wondering whether it might be something we might continue in the longer term. So just looking at patient outcomes, we were able to connect our laptops, we're able to tether them to our phones, so we could log into our hospital records system and see the patient's notes when we were seeing them. So we'd have a list of who was coming, we could see their clinic letter, we knew what we needed to skin test them for. And then, because it was either myself or a senior CNS there, in almost all cases, we were able to make the final decision about what was going to happen next for that patient from the vehicle. So for lots of children, that meant they didn't need to come back for another appointment in the future, or, and they didn't need to have a telephone consultation. So we could do it all there and then. We could sort out prescriptions, action plans. If we'd made a new diagnosis, that kind of thing could all be done from the vehicle. And we could do our dictation and clinic letters from there as well. So it was great. By the time we left, everything was done. We had 4 people who didn't attend, which is surprising because they had all manner of communication, but I guess you always get that. And you can see that 77 of those patients, so well over half, were discharged from that appointment, which is good. Next slide, please. Okay, so parent feedback. I just wanted to look at really simple things, comparing the vehicle with coming to the Children's Hospital, mainly for management as much as anything. So we looked to see here who'd been to the Children's Hospital before. And actually a third of these children hadn't ever been there, but I guess a lot of these children are young children and it's maybe their first appointment. So that's maybe not entirely unexpected. Next slide, please. So looking at the number of children who'd previously been to outpatients before, we asked if the journey was easier or not, which is maybe a bit of an unfair question because they could park right outside. They didn't have to negotiate inner city parking and all that kind of stuff. So for most people, it was a lot easier to go there. And then the bar chart just shows some of the responses that we asked for. So parking is obviously easier. No one had to wait because we really kept time really well, which was good. There were no parking charges for parents. And a lot of parents at this point, so we're talking a year ago, were really pleased not to go into the hospital because lots of people are frightened. And in general, it was easy to find, although sometimes patients didn't receive all the relevant information. So that was a bit of a shame. But I think admin issues were quite an issue at this time because admin were so busy. So many things were being changed, having to contact so many people that sometimes things fell through the net. Next slide, please. And then I asked if people thought it was acceptable. So everyone thought it was acceptable, although one person thought the space was a little bit small for 4 occupants. I would say it's actually bigger than a clinic room, but that's a fair comment. It's not unreasonable. And everyone would be happy to come back again in future. So that's really good to know. We didn't get lots of people being terrified of having testing done there at all. A couple of people asked if we had emergency medication if things went wrong. But it was a really small number of people and they were very easily reassured by our provision. Next slide, please. Okay, and then I just asked if people would prefer mobile or hospital. And lots of people were very happy with mobile clinic appointments. So that's something that we need to hold on to, I think, for future planning. Next slide. And these are just some of the free text comments that we had. So there's a lot of comments about parking. And quite a few comments about directions being a bit vague, which is also fair enough. But we didn't really get many bad comments at all. I think someone wanted provision for cyclists, and one person commented on the lack of toilets, which is completely reasonable. So we didn't have any toilets at all by Ashton Gate Football Stadium. We did for staff, but not for patients. The Mal's a shopping centre and that was open at the time, so people could have gone in there if needed, but it's a very fair comment. It's not ideal, definitely. Next slide, please. So now we've caught up on our skin testing. So patients have had their Attend Anywhere remote video consultations. We've done the skin testing, so we've cleared up the diagnosis for quite a lot of people. But of course, one problem always leads to another problem. So what do you think happens next? The next problem is that now we've got lots of children with skin testing results needing food challenges, and what are we going to do about that? So I'm just going to go through that as well with you. Next slide, please. Yeah, so longer food challenge list. And by the end of the summer, so we're talking September time, we've now got the situation where clinic rooms are starting to be offered up again for face-to-face appointments for some specialties, and everyone wants to be one of those specialties that gets the room. So again, and it has to be socially distanced. So rather than doing 7 patients in a clinic, at this point we're down to about 4 per clinic, sorry, per clinician clinic, and we haven't got as many rooms as we used to have, so we can't see as many patients. Next slide. So this is where the Spire Hospital came in. So this is the Bupa Hospital in Bristol. So they offered us their paediatric unit for free to be used, I think, for a 3-month period or so between September and New Year's Eve. So their paediatric unit is an inpatient unit with, I think it has 4 beds and a small nurses station in the middle and a treatment room. So our consultations had to be held in a bedroom, which felt a bit strange, but it was a space. Again, patients would drive to the hospital and then they'd be called, and then one of the HCAs would walk downstairs, meet them and escort them up the stairs. So this was a bit of a palaver. And if you're running late with a patient and you've got 3 clinicians there, then there's no waiting room for them really. So people have to sit in their cars until they're called. So it wasn't the most smooth running of clinics, but it was a great way of seeing people that we needed to see. So it was really helpful. Next slide, please. And then we've got the Nightingale Hospital. In Bristol, the Nightingale Hospital was based at UWE, which is the University of the West of England. They've got a huge conference centre. It's just massive, and they also use it for all their exams. So 301 beds were put up in there, and it was great that we didn't have to use it for COVID patients. Can I have the next slide, please? So we took it over. So this was a massive project. It was bigger than the mobile allergy clinic because there's so much bureaucracy to deal with in this case, which we really hadn't had to deal with before. So we set it up to run low-risk food challenges. We did some supervised feeds. We did our biologics injections, so Xolair, Mepo, and we also gave IV infliximab infusions to patients with gastrointestinal problems. So we took a gastro nurse with us. We did test doses of SLIT, we did a bit of antibiotic delabeling and some simple drug allergy clinics, and we also held an outpatient allergy clinic there as well. So on the days that we were there, we were only there once a week, we would take the whole team. So we had a consultant with us, all the CNSs, so 3 CNSs and myself, plus 2 or 3 nurses from our day case unit at the Children's Hospital, which had only got 2 beds open at the time, so we took half their staff with us. And we had to take all the kit as well. So this was a bigger project, but the largest bit of this project was the fact that we had to develop an operational model for it to be set up as a field hospital. So I'm just looking at the comments. I'll answer those at the end. Yes, so it was set up as a field hospital, which meant we had to go through many hoops and produce something like a 120-page document. Next slide, please. So they had a Nightingale reuse project board who met for a couple of hours twice a week. And we used this time to develop our field hospital operational model. At the same time, the Eye Hospital from Bristol were setting up a unit there as well to do lots of investigations as a kind of one-stop shop. So we had a 12-bedded area, and the Eye Hospital had a similar sized area at the other end of the building, so there was no mixing of adults and children. We managed to make 2 separate entrances, etc. So you might think that because it's the Nightingale that it has oxygen, etc. So it does have capacity for piped oxygen, but the Bristol Fire Service were not keen on that being switched on. So that meant that we would have to take our own oxygen with us. So we did that. We took cylinder oxygen. The resus trolleys are obviously set up for adults with COVID, so we had to have those adapted, had to take out specific medications as well. We needed a safeguarding visit, so we had to be sure that people couldn't get in. There was security on the desk, so it was easy from that point of view, but we had to check exits and things like that. And of course, the main risk in a 300 bedded unit is a small child disappearing and not being able to find them because it's massive. And then we needed to think about pharmacy. So we've got the biologics and cold chain to think about. So we could keep drugs at the Nightingale, but we weren't very happy about leaving biologics and expensive medications in the Nightingale fridge just because they're so expensive. If something goes wrong in the middle of the night, what's going to happen? Who's going to get called? Are they going to be lost, etc.? Who's going to know about it? So again, that was all done by Cool Box. So pharmacy have a special temperature controlled and recorded Cool Box. It looks a bit like something you might put a kidney in. So that was me in the morning. I take my children to school, go to pharmacy, pick up the drugs at 7 o'clock, drive them to the Nightingale. So again, it's not something you'd want to do on a permanent basis, but something that you're happy to do if you need to. We did have to get fire service approval, and then the CQC wanted to come around and do a full inspection. So that was a little bit stressful. And then, of course, we needed equipment. So we needed infusion pumps because the ones that were at the Nightingale were very old and had been pulled in from who knows where. All that kind of stuff had to be brought out. So the ward sister had to do a lot of work, and we had to get people to take it out for us. Then we needed to take out the paperwork. There were some IT issues because it was North Bristol Hospital Trust who were manning the Nightingale. So we needed to get it transferred into our hospital trust system. So that wasn't immediately straightforward. And then finally, there are the challenges of moving clinical staff. So as you all know, it's quite easy to be in a comfort zone and to be happy to continue working as you're used to. But when someone mentions doing something different, especially something like this, it upsets quite a lot of people, makes them very anxious, and that again needs to be looked at and dealt with properly. It's not fair just to move people without preparing them. So that took a little bit of work. And actually everyone really loved it. Once they got there, they were really happy, and it was very successful, which is good. Next slide, please. So I've just got a few pictures here. So this is the unit we inherited. So this is what it looked like when we turned up. We did get a few walls built, just temporary ones. So this is a wall in the process of being built just to stop children escaping. But also because it does look quite frightening as a parent if you walk into this unit and you see 300 beds, and we didn't want to upset anyone. And obviously some parents may have lost relatives or whatever, or not seen relatives for a long time. So it was all very closed off, so people couldn't see it. Next slide, please. And this is what we turned it into. So it looks far more friendly, I think, at this point. And we used our little pop-up signs from the bus, and we had the flags outside and things like that. I actually really enjoyed working there. I felt that it was great to have the whole team there, and at least one consultant for a day, because we got through far more patients than we might otherwise do on a day. So I think for me, the learning curve would be to have a unit for a day rather than to have 2 beds, every day. But that's maybe not quite so easy to sort out. Next slide, please. That's my next project. And then we did the usual Google Forms. So these are some of the procedures that we did there. So all the things I've mentioned. We also gave a flu jab to a child with complex needs who had egg allergy and a cleft palate and who didn't want a nasal flu vaccine, and who couldn't have a live vaccine either. So that's the child at the bottom. So it's got a nice spread of different investigations and procedures, and 72 responses in all. Next slide, please. And again, we asked where people would rather be seen. And some people, so 9–10% did want to go to the Children's Hospital. I think logistically, the Nightingale was a little bit harder to find if you're from the other side of town, because it's in North Bristol, and South Bristol is like another land. But most people didn't really care where they were seen. Next slide, please. And again, I asked for lots of comments. And again, we got all the comments about parking. So I think the lesson for the future is when we're building healthcare services and when we're thinking about what we might do in the future, parking's obviously the key. A few people commented that there were no drinks facilities, and there weren't very many toilets either, which was tricky. But people were really happy to go there. had a lot of staff for the patient workload, I think, just because we were very safety conscious. We didn't have any severe reactions or anything like that. So again, it was a nice success story. And I think that Jonathan Hurahan has done something similar over in Ireland by taking over a sort of Nightingale equivalent facility for a period of time. So I think it's something that we could think about doing in future. And I think maybe some of allergy could move out of the main hospital. Next slide, please. And if you just click it again, there'll be a message that comes up. So I think this is the key learning point from COVID-19. So it has been a catalyst really in kind of persuading us to work differently and to be more creative with the things that we do. So this is just a quote about that really. I think it's really important that we do think about what we're doing from time to time and we stop and look at different ways of working. And we've been asking for video consultations for certain patients for a long time. And it's interesting, isn't it? COVID comes along and a week later, everyone's got a Trust laptop and access to attend anywhere. And there's no concerns about funding, not from our end anyway. So things can happen with the right prompt, I think. Next slide, please. So just in summary, so I don't take up too much of your time, I think the key thing is that it's been really successful to do these projects. It has involved an awful lot of background work, particularly with going to the Nightingale, but we've had some really positive outcomes. And our waiting lists are definitely less than they would have been if we'd not had the chance to do either of these initiatives. So it has saved us from blocking up future outpatient appointments with patients that we wouldn't have been able to see otherwise. And I've been really surprised by the flexibility of patients as well. I thought we'd have lots of safety concerns from families, perhaps about the risk of anaphylaxis with testing or, you know, being out of a main hospital. But we really have not had very much of that at all, which I think goes to show how much trust patients have in us as healthcare professionals. And that's a real responsibility as well, isn't it? So we should always be aware of that and definitely not abuse it. And the other thing I'm keen to look at going forward is looking at how we can get some of allergy and asthma, as my other role, into the community. So our hospital, even before this, was short of space and everyone's pushing to get rooms and things like that. And is there any way we can get these lower risk procedures out of the central hospital? I don't need x-rays. I do need to be in a safe place. But if we can get out some of the low risk procedures, then we have more space to get through our complex drug allergy clinics and our subcutaneous immunotherapy, all this kind of stuff that we're struggling to find space for at the moment, and we're already struggling to find space for before. So I think I might look at the South Bristol Hospital for some of this. We had looked at retail units that are now redundant, but the insurance is complex in going into those centres from their end rather than from our end. And we're also thinking about other new ways of working, so embracing remote access really. And we're going to do some home introduction telephone clinics so that we're not bringing patients back to find out how they're getting on. So we're going to offer morning clinics once a week. So if we have someone with egg allergy, perhaps for an example, we might send them home with the egg ladder, as long as they're not in a very high risk group, with details on how to work their way through baked egg and lightly cooked egg. And we can touch base with them every 4 months or so to see how they're getting on. And that way, it also means that if someone comes for a baked egg challenge and they have a reaction, quite often it's tempting to either go home and not eat baked egg again, or to stick at one level and never increase it. So by doing a telephone home introduction clinic, people can introduce things really slowly at home with probably more success in getting stuff back into their regular diet. So that's a bonus. The other thing we're thinking of looking at is a remote supervised feed clinic. So we'd use Attend Anywhere for this, and we wouldn't have that many appointments. But normally when we do a supervised feed, we give patients hourly appointments. They come in, they have a quick check. They've got half an hour to eat their dose of food, and then they sit in the waiting room for an hour. And meanwhile, we'll see someone else. But that obviously isn't an option because of social distancing. So if we can potentially do it remotely for our very low risk patients, that might make life a little bit easier and will also help our waiting list, but obviously we need to be safe. Attend Anywhere would be a good media for doing that. We could see patients and give them their half an hour to eat their food at home with us lurking in the background. But it's quite hard to move lots of patients in and out of waiting rooms virtually, because we need the patient to be able to alert us if a problem happens. And that's the tricky bit, because at the moment you have to invite them back in before they can speak, and that obviously doesn't work. But these are just some of the things that we're doing, and it would be really useful to see what everyone else is doing too, I think. And next slide, please. And that is my conclusion, really. But thank you so much for listening, and to the Anaphylaxis campaign for inviting me to speak. And I hope it's been useful to people. But I'm very happy to answer any questions. So thank you.
Thank you very much, Deb, for that fantastic presentation. I think over the last year, everyone in all their different spheres of life has been having to think outside the box a bit. And I think what you've done is a fantastic example of an NHS service that has had to work so very differently during this very, very challenging time. And it's brilliant to see it from our perspective in terms of the allergy services. So that's fantastic. That was fantastic. I also love your quotes.
Thank you.
I'm going to certainly hang on to some of those myself. Absolutely fantastic. Now, we have had a series of some questions, and some have come in while you've been speaking as well. So if I ask you a few questions first, if you don't mind, and then we'll
That's fine.
How time goes. What we will do is we will make this presentation available to people on our website, and we know that lots of people who wouldn't have been able to listen live do actually access the presentations on the website later. So we'll make that available, and we'll also make the Q&A available as well. So you've described lots of interesting, innovative ideas that you've been taking forward during this very difficult time. What's happening now? When do you anticipate that allergy services will get to anything like normal in your service in particular?
Yeah, that's a good question. And I think you're right. It's very different everywhere, isn't it? But in our service, we are, apart from the food challenges, we're almost back to normal. So we've been doing face-to-face appointments with our normal template since January. So we're back up to full capacity on a face-to-face outpatient basis now. What we are struggling with are the food challenges. So the Nightingale was great, because I didn't say when that was, but we ran that between November and March. So the Nightingale was decommissioned at the end of March. So we've lost that space now. And we normally have a 6-bedded inpatient unit. We have 2 beds for research, they're dedicated beds. And then we have 4 patients in the general unit, but now we've only got 2 beds, and we obviously have to share those with everyone else. So that includes endocrine, gastro, dermatology, all those kind of things. So we are actually really only doing about 2 food challenges a week rather than 10. So we're not hugely behind at the moment because we've been using the Nightingale, but very soon that will become an issue. So we're hoping that the social distancing may change soon, so we can get back up to full capacity. We're also looking at using the research beds because there's less research going on, but again, that could change soon. We have run a few Saturday waiting lists where we do food challenges all day with 3 or 4 nurses, and we've used all 6 beds plus all 5 clinic rooms that are attached to our daycare unit for that as well. But I think people like to do that in the winter when there's not much going on and they need some money for Christmas, but no one really wants to do that in the middle of the summer. And I think people are a bit tired now as well.
Yeah.
I think, and thinking all the time about how you're going to change your service is quite exhausting mentally and emotionally, even if physically you're not doing as much as you otherwise did. So I think people need a nice summer to catch up, really. So yeah, it's hard.
Yeah, I think we'd all have sympathy for those of you on the front line who've been providing services in very different ways. And just in your presentation, it came over to me certainly quite strongly, the sheer amount of work you have to do to have change.
Yes, a lot,
all
isn't it?
based on risk, and you have to be sure that you cover all those eventualities. But it's very challenging and exhausting, and you can't just turn a switch and something looks very different. And you know, we shouldn't underestimate the amount of work that you and the team have put in to introduce these very innovative solutions. As you can imagine, our helpline has been flooded with people who've been worried about when their next appointment will be, and you know how services will be provided in the future. You mentioned the change that happened quite quickly for you around remote working and having access to IT, etc., which you may have been asking for in the past, and had to go through various processes pre-COVID that was speeded up. Do you think that this is very much the way for the future, and that increasingly allergy services will be provided in a more remote way from the model that we were used to pre-COVID?
Yeah, I think we have to be careful that we don't get pushed aside as a specialty, because it's important that we do still have face-to-face contact with some of our patients, and most of our patients, to be fair. But there are some situations where it could be very handy. So, for example, if a child is referred for an egg allergy, just a simple mild egg allergy, and there's a 5-month waiting list for an appointment, sometimes what you find when you see that child is that they've been told by their GP to avoid all nuts and sesame. So you end up with a, I don't know, 1.5-year-old that's not introduced any of these high-risk foods into their diet. So if at the point of triage, when the GP letter comes in, we could offer a virtual appointment, we could address all of those things with that family. And maybe a skin test to egg doesn't really tell us anything we don't know, if that makes sense. I mean, it's helpful to have, but it's not essential. Or it can be waited, you know, people can wait their turn for that, but as long as they know how to introduce things in the meantime, then that would be good. So that's one example. And there are things like referrals for idiopathic urticaria, and sometimes that's very clear to spot from a referral letter that it isn't a food allergy. So again, if you can have that conversation early on, that saves someone 6 months of anxiety and fiddling with their diet and all that kind of stuff. Another example might be hay fever. So if you see a hay fever referral and they're not using optimal treatment and they're on treatment that we wouldn't necessarily recommend, again, you can maximize their treatment before you see them. And if that's effective, then potentially they may not need immunotherapy. And if it's ineffective, you know that, rather than having to treat them for another year to see what they're like. So that kind of stuff, I think it's really helpful. And follow-up appointments as well. So there's definitely a role for it. And I think the other thing is, I keep going on about this all the time, is getting stuff out of the hospital environment somewhere and taking it somewhere else. So I think we almost need some kind of like an intermediary care centre. So it's not primary care, it's not secondary care, but it's somewhere where we can deliver care to the community to save them coming into a hospital and to save our space. And I know there are some community allergy clinics, like at the Whittington, for example. So I think that's a really good initiative. And maybe that's part of the way forward too. So there's lots we could do.
It's about sharing these innovations, isn't it, across the piece? So there may be a clinic up in John O'Groats who are trying to reinvent the wheel, you know, and having the sort of the conversations around your community to share these fantastic ideas and ideas about how you go forward. You touched there on primary care. Did you work differently with primary care during this period, and do you see scope there that perhaps could be built on?
I like that question. So we didn't, but I'm very keen to do that. And I am at the moment working jointly with primary care for asthma. So to try and stop patients being referred in for asthma, getting to them earlier, reviewing them jointly with a practice nurse, so that, you know, they learn from me, I learn from them, the patient gets helped earlier on and in a local environment. So asthma is a really big problem in our area. So I think commissioners and people are much more keen to push that for asthma than they are for allergy. But I think it's equally important, and I think we could run some mild food allergy clinics out in primary care, you know, for monoallergic children or young children with one allergy. I don't know that they necessarily need to come into hospital, and I don't know that they necessarily need to see a hospital consultant either. So people are frightened of allergy, I think, in primary care in a way that they don't seem to be frightened of asthma. So they're more reluctant to touch it and very scared of making the wrong decision. So their referral rates, I think, are higher, but it would be good to upskill people, I think, and that would provide better care for people in general. So watch this space.
And
maybe
that's
next year.
a subject that's very close to our hearts at the Anaphylaxis campaign, you know, the training in primary care to give the primary care space more confidence. I think is a key thing that we're certainly very, very anxious to see go forward. To make all these changes and to do the things you need to do, presumably you had to work with your local commissioners. Have you got any tips for people who are forward, how you approach that? Because I know that's been an area that many people who've been trying to be innovative have found a little bit difficult in the past.
Yeah, so for those two initiatives, we didn't really. So the bus was funded internally using a COVID fund. It didn't involve the commissioners because it was a temporary measure. And I don't know that it's something we'd want to continue doing, or we might use it for a one-stop shop where we did everything, but I don't think we would just want to do skin testing on its own unless we couldn't see people face to face. But maybe there's a role for a face-to-face clinic in a vehicle like that. And the Nightingale, again, that was all done centrally. So my manager and myself worked quite closely with the Nightingale Project Board, who are all managers and clinicians who've been taken from other centres, other hospitals. So quite senior people. But in terms of the asthma primary care clinic, so what we have done is offered my services for a day a week to the community. And the hospital are taking the hit for that because no pressure on me, but hopefully outcomes will change and that we may reduce subuteral over-reliance, we might reduce acute admissions, that kind of thing. But I think that's a lot of work for one person to do. I'm not sure it's achievable or even measurable, but that's why I always insist on having one of their nurses sitting in with me so that they learn, and I make them do the consultation and I will help. And we've got quite a lot of stages to it. So we plan for what we'll do next and what we'll do next if that doesn't work and so on. So there's about 3 steps that I leave them with before the patient would need to come back. And we're cascading it out to other GP practices in more deprived areas. So they're very keen to take it on. So I've almost got a year to make a difference of some kind, even if it's only small, to demonstrate that we need input and people employing to take it on in the future. So if that works, hopefully that might happen. But yeah, it's tricky because no one's got any money at the moment, have they?
Yeah. We're getting lots of comments in the chat. They tend to be less questions and more saying, gosh, how fantastic you managed to achieve that.
Oh, really? Oh, thank you.
There is a question here, which I think is interesting, because Deb, you are one of the top, not to flatter you, but I will, you are one of the top allergy nurses across the UK, and not every centre, every allergy clinic is fortunate to have a nurse consultant, such as yourself. And one of the questions that's come in is about the fact that you had to do lots of planning and sorting of the legal side and the safety side. Do you think that it would be more of a struggle perhaps to introduce the very innovative steps that you made without somebody in your particular position? Do you think that I think
that's a fair point, and that's probably true. I think it makes it easier being in a senior position, definitely. But I have to say that for the Nightingale, my manager, my non-clinical manager, who is a hospital AGM, I think she just saw that we couldn't carry on with ambulatory care. We couldn't meet the needs of people, and we had to find somewhere else. So she was very keen to do that. And we worked really closely together. So to be fair, she did as much of the work as I did in that situation. So she, dragged in the safeguarding nurse, and we delegated to our matron to sort out the resus trolley with the resus team. So I didn't do all of that myself, but it was quite stressful because it was so intensive, and we had our weekly meetings, and then everyone's asking you if this has happened, and that's quite stressful. So if you're not at a higher band, it's perhaps unfair to put someone in that position. I definitely would have a manager on board as well at the same time. So if you're in a service with a manager that's engaged, then you may be successful without being at a higher band, but I can see that in some places it could be difficult.
Yeah, and you mentioned Jonathan Hurricane and his work in Ireland as well, and getting we've got some fantastic medics out there. Getting them on board as well can, I'm sure, be really, really helpful.
That's true, actually, because we did try and take out other specialties to the Nightingale, because we could have had it for more than one day a week. But a lot of them weren't happy to go, so they didn't. A lot of the CNSs didn't want to go. So endocrine, for example, and other centres, they didn't want to do it. So if your consultant doesn't want to go, you're on a loser already, aren't you? Really. So we're lucky that we've got quite a dynamic team, I think, and the consultants I work with are all really up for it, which is great. But they are also one of them is also an ED consultant as well as an allergist. And the other one is a general paediatrician as well. So we haven't got full-time allergy consultants. So they could only go one day a week. We couldn't go more often than that because we'd be taking them away from their other clinical responsibilities. And I was happy to supervise it, but I think the nurses, the CNS nurses, were more keen that there was a medical consultant there as well, which is fine because we, like I was saying, alluding to, have to work with the whole team, and if people are unhappy, it's going to be a difficult model to implement. So if we'd been there for longer, once people start to get confident and comfortable, then yes, you can expand it and it would have been fine, but it was just a short-term 4-month project.
Yeah, but I'm sure it will have implications for how you work in the future, and it's great that other centres can hear about what you've been able to do. I'm going to ask you, because time is ticking on, I'm going to ask you a question on my part, actually, while you're there. How do you think the anaphylaxis campaign can work more effectively with allergy clinics up and down the UK? We're very lucky. We do have a very strong cohort of healthcare professional members, some of whom are listening to this today, so that's great. And we've got a fantastic clinical panel, as you know, which meets regularly, and you're part of that panel. But we're very keen to support as many clinics as we can. Do you have any tips for us?
Well, I guess the first thing that springs to mind would be a membership related question. So is there capacity for institutional membership rather than individual membership? Because I think sometimes nurses and other professionals feel that they may not want to pay out for an individual membership for anything. I think there's always this thought, isn't there, that perhaps that why should they be paying for things when they're working for an establishment who isn't funding all these things. I'm not saying that you're expensive, but I just think it's a good way if you could infiltrate all centres, then that it's easier to work together, isn't it? If everyone is aware, I know everyone's aware of you, but if everyone is aware of each other as well. So if you are the uniting bit in the middle that everyone goes into the hub and spoke, if you're the hub in the middle and everyone knows that you're there, then that would be brilliant. And if people are all getting their institution to pay, you could perhaps charge a bit more. And if anyone's got a question, they can come into you and you can put them in touch with someone who you know has done something similar or is working in a similar situation. So that might be beneficial. But it's also really good to encourage everyone to be a member if they can as well, because obviously you have all the information, you're a great resource to patients. And I think people perhaps don't always recognise that you're also a resource for healthcare professionals, because maybe sometimes you're seen as a patient charity, which obviously you are, but maybe a bit more wider awareness or a wider campaigning to healthcare professionals that actually you're there for them as well. I don't know what other people might think.
Yeah. No, that's certainly really helpful. There's some really helpful comments for us to take away. So, as I say, we've got some really interesting comments, which I'll certainly pass on to you because they're very complimentary, Deb, about what you've done. I think people who've been listening have recognised just the extent of the achievement that you've taken forward during this particular period. Anyone who wishes to ask further questions after this webinar is over, please do just send them to us at the Anaphylaxis campaign. We'll incorporate them into the Q&A, which we send to Deb, and then we'll make sure that all those answers are available to everybody. But on behalf of the Anaphylaxis campaign, I'd like to say a huge thank you to you, Deb, for such a great presentation, such a positive presentation that shows what can be achieved. You know, when you think of all the sort of strictures around you, when we have a situation like COVID and people think outside the box, it's amazing what can be taken forward. So big thank you to you, and a big thank you to everybody who's been listening to this webinar. And as I say, we will make it widely available. So thank you very much, everybody.
Thank you, Lynn.
Thank you.